makes your life in the operation so much simpler. So during the operation, lift the prosthesis out physically from both foot. Do not allow your system to rotate the leg and dislocate. So both dislocation and relocation I always do with mechanical input. You provide exposure and release balls coming, and if you've got a fixation device, leave it in until you've dislocated, then put it back in, take the fixation device out, and then re-dislocate. So the goal for treatment really are frontal union and to maintain and obtain a functional prosthesis. And you can do this in many ways. Prevention, protect your weight bearing and waiting to see if it knits together, or revision of the prosthesis of fixation and fracture. So type A fractures, this is your rib trochanter fracture. What are you going to do with this? How many people will use it and see what happens? How many people want to fix it? What we see is that if it's undisplaced and it doesn't displace more than a couple of centimeters, the person isn't read out that positive isn't too painful, you maybe should watch it. But if, on the other hand, it moves, that was decided, people decided to watch it, it moved, you bring it down and fix it. So the treatment isn't a critical approach, it is more an empirical approach. We have the B-type fractures, these B1, B2, and B3. And that was the question we had for you. And can we have a show of hands? How many people here think that should be fixed? So that's about 10-15%. How many people think it should be revised? So more people potentially think it should be revised. Okay, and that's essentially what was done. We'll come back in just a second. That's the second part. Who do you think should be treating that? Fracture surgeon or a revision surgeon? Okay. We'll come to the logic behind these decisions in just a second. Now, what do I have on that? What do you think we should do with that? In my book, the most important thing when I'm looking at vertebral fracture is to see, is the prosthesis stable? If the prosthesis is stable and it's not embarrassed, then you can make a case for fixing the fracture. But if your prosthesis is inherently unstable, then you write it. And that's a very simple algorithm. So that was fixed, which is against the logic we used. What do you think is going to happen now? Low orthopedic process. Okay, so it fails. So obviously, it was thought that the reason why it failed is because the portable strut graft has been used with cabling, and therefore a strong metal blood has been used. What do you think is going to happen now? It failed. So what do you think we should do now? Go back and do exactly what you thought to do in the first place, which is to take it out and replace it. I don't know if you use these. This is the cable plate system. It's excellent. If you haven't come across it, it's an excellent system, and it has 3 different kinds of cables. That locks into the threaded cable that Matthew was talking about yesterday, and you can then pass the cable through that eye and cable it onto the plate. You can then drill a hole through the second part of the cable, pass this plug into it, and then put a cable around to hold it securely. In certain, when you have a headset that locking through, you can fit one of these things into the head of the headset, not that particular one, it's the 4th kind. You can fit it to the head and put a cable through. And these are the cable passers. I personally think that these cable passers from Synthes are not as good as the cable passers you get from Zimmer, but it doesn't really make much of a difference. This is the plate with the cable I locked into the logging hole, and that is a simple fracture in which one of those has been used. There is also, to go with the plate, you have a lateral cable, lateral hook attachment that you can screw onto the any of the plate holes, and then you can clip screws on either side of the plate. And it comes with 4 or 8 configurations. You can bend these spider arms around and use it to fix your periprosthetic fractures. And this is a range of dedicated and pre-contoured plates that you can use for different parts of the femur, and they are very easy to use. Looking at the zipper cable system, which we also have housed in our hospital in Sunderland, the only problem is that the screws are placed fairly far apart. They are non-working compression plates, and I find the Synthes plates more useful than these, though we do use them on occasion. The Biomech has a PLD cable system, which is a trough-and-tray grip. They use cables, no angular stability through these holes, so it's not something I use. This is very popular in Britain, and I would recommend that if you have a daughter with long hair, it's useful for her to hold her hair in place, but don't use it to fix several fractures. That is the good workhorse that I use very frequently. It's the Darwin system from Stryker, and there's a lot of clinical experience. It works extremely well, and the only worry is because they are plate cables, you can get wear particles that act as a third body if they go to the joint. And then these are other cable systems available, but there is no angular stability because they don't allow locking screws. So many companies make different kinds of plates, and it's important to be aware of what is available and what works for you. Going back onto the C-type fractures, I'm very grateful to my colleague Matthew for this picture, and he made a very valid point that the old days he would span this with a blade. He now tends to use the principle of absolute stability and get a compression screw across this and then fix it with a neutralizing locking plate. So that's the fracture, and that's how he fixed it. So infractural fractures is the easy method of treatment. A1 fracture, graft cortical perforation with readings. If it's a cemented hip, ensure the cement is clean to the endoscopic surface. If it's an A2 fracture, use surplus. No problem. Okay, thank you very much. I think it's well done. And so somebody has actually looked at this, and they say for these very prosthetic fractures, if you treat them with blades, with cables below, so you put a blade across the very prosthetic fracture, cables proximally, cables distally. Or you use the blade with cables proximally where the prosthesis is, and distally bicortical screws. Or a blade with proximal unicortical screws and distal bicortical screws, or a blade with proximal unicortical screws plus cables and distal bicortical screws, or cortical allografts and cables. So they did this experiment and they tested these constructs of axial compression, bending, and torsion. So which do you think is going to be the best? This is the choice. These are the 5 choices. Which do you think is going to stand out best to this testing? If it were your polyprosthetic fracture, what do you think would be most stable, most successful? Number 3. So the gentleman feels that it's possible to incorporate this to bicortical screws. Any other takers? 2. Okay. 2. So you've got 3 offers. One gentleman says 3, one says 2, and one very wisely says 1 left. So let's find out. The answer is you're absolutely right. It's a blade with unicortical screws proximally and bicortical screws distally. If you're going to use cables for strength, multi-filament cables are better than monofilament cables. And lock compression plates, which we now use routinely for all these fixation constructs, they are well suited to osteopenic osteoporotic bone. They have a fixed angle construct, as Matthew has explained yesterday. It helps preserve the blood supply, and if you are skilled enough, it allows you to use it without movement side to side. And it has counter combination balls, so if it's a long plate, you can angle your screws through the end and use a locking construct in the rest of the screw hole. If you're going to use cortical strut allografts, use cables, not wire, to attach. Use 3 cables in each segment, proximally and distally. And Haddad says that you should use 2 struts lateral and anterior to avoid medial stripping. And I actually find it difficult to think if you're going to use 1/3 coverage on the lateral side and 1/3 coverage anterior, that you're going to need much of the bone vascularized. But that's use much 1/3 lateral in both bone, and freeze dry are less stable in torsion than fresh frozen. The problem is getting fresh frozen strut allografts when you need them, unless you're in the center that uses it all the time. So we can't do any of the talk, and these were the two cases that we put up in the beginning, and you promised to treat your newborn wife, and this is one of them. What do you think I should do with this?
Remove the implants and fix the fracture.
Sorry?
Remove the implants and fix the fracture. Because you said that this is a frail lady who's...
Yes, 92-year-old lady.
Bedridden.
Well, she's in the nursing home, so, she walks to the toilet and does it.
A girl will still and fix the fracture.
So you want to build and fix the fracture?
No.
Yes, I am.
Removal of this Thompson and total weight with mesh and the graft, allograft.
Okay,
And
so
the stem.
revised to you anticipate any problems there? Do you think that's fresh, or do you think that's been there for a while? You think that's fresh? Because looking at that, I thought it was over as a long-standing chronic problem, and the reason which you were is because this is sort of held in a bottleneck at the acetabulum, and the forces are being translated to a femur. That's basically what we did. We used some fossilized allograft and then stabilized it, because we needed, as Matthew explained to you, the main priority is to allow it to sit up and stop it from dying of hypostatic component. And this is the last case that I had, remember? And if you remember, we said that there was a loose, painful hip that had had a purpose-led fracture. Somebody had fixed these powerful straps, and that was loose. So what are you going to do? How are you going to treat that fracture? Well, we said there's no point actually treating just one part of it. a definite solution in a rather dramatic way because the lady is only 56 years old. Thank you. Before finishing this number, please. For discussion.
Modification is about the patient. How old is she?
94.
94. And she had a Thompson on the right side.
Yes.
What I want to say, not agree.
Unfortunately, she's got a grossly infected left lower toenail from the new walking boot. So we've already heard the talk on these fractures. Two choices for you to talk about. Fixation or replacement. We have a show of hands for fixation.
Hands up for fixation in this patient, 60-year-old with no fractures
And an infected, grossly
and an infected ingrowing toenail. So she has an infected ingrowing toenail. Hands right.
How bad is the infection? How bad is the infection?
Yeah, it's been on for a while, and it's something like this part of the foot. It needs to come off.
That's something you need to say. So the light is up to half the leg.
No, half the foot.
On the foot, okay, that's significant.
It is. So again, so who's the go for fixation?
Hands up for fixation. Infected foot and back fracture. Hands up. Hands up for replacement.
So that you have to forget about the growing toenail, treat it first, and then think what you are going to do.
I must say that the reason really was, because you're in the 60s, very fit, your chance to fix it is very short. If you wait till you go to town, you've lost that chance.
So it means that growing toenail, no infection whatsoever, under antibiotic cover. Put a good DHS. You have a good chance of being it.
DHS, good chance to you. Okay, should we see what's children? Young women's schools for a very small incision after removing the toenail, wrapping the foot up and antibiotics. One concern with my operation notes is sure how long it took. It took a long time. If things take a long time, it suggests that the drill will possibly went in more often than more than 3 times. So how do we know that isolation?
When we're buried for at least 2 months,
Okay?
I would do that.
That was one way over 2 months, any other ones?
How do we mobilize the patient? We mobilize a fully weight bearing, partial weight bearing, and non-weight bearing. We have one bearing is tolerant of him.
Non-weight bearing for 3 months, really like.
Non-weight bearing for 3 months.
No weight bearing.
Partial weight bearing. So we have all 3.
Now, unusually for hip fractures, this lady is able to comply with what you tell her. She can do non-weight bearing, she can do touch weight bearing, she can do fully weight bearing. In this case, because it's taken so long to do the operation, we were slightly concerned that there may be some more holes around here, maybe a bit like a pet point. So we kept her away from it. But she slipped on the floor. Not much on the floor, really got down into a chair.
That's one suggestion.
And the reason for that historical, actually, they had looked rather, only really, it's still rather good, and it could be on the other end as well.
Any other suggestions then?
I think the thing we need to do here is discuss options with the patient.
Yeah.
Because the thing is, you've got that infected foot, now you've got a more drastic fracture, needs to be treated for a bigger operation, more risk of infection. So I'd splinter, treat the foot infection, then start thinking again after I've resolved the infection of the foot, what to do with the leg.
Okay, you said there's no rush at this stage. So say now, so far, we're going to eradicate the infection completely.
Remove the pain and all that is now. You must project.
This meal while another which you already know the station of very good fashion can include fashion ground of position or the disease. Sometimes most of the around position after the parents of fashion care the original fashion include only one. And in some cases the real one of these also replace with medications.
Yes. To leave one school and move to schools.
This was forbidden by Charles Brown. Okay, so you will find out other children's schools who are putting DHS to stabilize the self-control function. Okay? Yeah, you will do that.
And you have quite interesting shape.
So custom management organisation. Okay, so most of the options are not so far. He's here. He's here. We are not in the information on the
I do intraabdominal interkneeling. Kneeling basic technique after reduction, not so wide because we don't want of this move and proceed with interkneeling, which is gives as this case.
Okay, so that's another so we've got four options. One is a ribbon screw and the HS, nails, or toe replacement. So toe replacement first.
Tell me what else you put in the you don't need to keep your hand down the time. You're going to have to vote.
Okay? Fixation, ribbon screw DHS.
What kind of schools? واحد يشتغل كلام تلفزيون خلينا نفهم
fracture seems to be on the floor or quite a big fixation. So we used to hang off 150 degree DHS to try and improve the biomechanics of fracture. And remarkably, this was able to deal with that immediate place, not gapping there, by 3 months to 3 months.
Sample content function is a unique function. It is subjected to high statistics costs in the world. So in order to then come down and give school, because usually surface and not like pitches usually fits. And in the model, you show us how they will facial in subtle content. Because the high bending statistics is very hard. How can we do
You see, in this nation, they're very versatile, very music here. And that's why we use the... So it's not like particular such as their fractions. Instead of being like that, this is more like that. So you've actually got a reasonably stable movement with about 100 high angle regions, 150 degrees. So actually, the quality of the fraction This is substitute of learning, Penny Snow, whatever I'm moving first. She was all waiting this, the next person. But while waiting, she thought she'd go for a bit of warm sunshine to escape the British winter. And unfortunately, she fell while it was abroad. And this was the treatment that was performed in the Canary Islands. That case of illness in the early, we need to go here.
There's no distance.
But there is one distance. And lots of others. I'll have to bring it down. That's the last one here.
Is it actually here? It's certainly not. It's totally exposed to start now. Not every business is safe. Okay, so what's the answer to the back here?
So,
all the movement on the fracture side.
exactly,
All the movement to the other fracture side, that is different.
fully stabilized and all the movements that we have is and it's not even one of these, they've not followed the suggested guidelines of reduction prior to surgery. Okay, so if those stay in place with this. Any option other than the first?
I don't know that it is safe for this will need much stress on the fracture side, and this will enhance manual. It will not be right. So I remove all this and put a hinge on it. Long story short, for the production.
It shows the importance of treatment structure. You know, the first time, the first thing I was doing the operation, it's never been doing.
I've been talking about energy selection assessment, both the trivial person and also the effects of the orders. Now, we already know these figures. There have been huge numbers of children based in the UK, 66,000 THRs in 2008, and 79,000 TPS. And that is set to grow. In England,
by 2030 there will be 16.5 million population over 65. So there's going to be a huge amount of resolved osteoarthritis. So the question that we look at is which patients, which prosthesis which we heard about in 4 minutes, and then which articulation, and then again what our second technique is going to use. Now what valuable to us as orthopedic surgeons is that we take the decision for the patient. Because if we do operation for the right patient at the right time, then we'll get a good result. So the history is critical, as is your examination, and your appropriate investigations. So what do you want to do for the patients? Well, one of the things you want to know is, have they got a brain pain, which really goes down to the knee, and that's the classic sort of pain that they describe. Some patients will only complain of knee pain. They also want to know how does that activity limited, are they stiff, do they have neck pain, do they have breast pain, is life becoming miserable? Because that's going to give you an idea of how severe these patients' symptoms are. We also want to know how long it's been going on, is it a rapid onset, or has it been going on months or years? And as I say, night pain, are they waking up at night, so much so that the pain is preventing them from getting a good night's sleep? You've also been aware that this sort of pain can be caused by other systems, not a brain system or musculoskeletal system. So there's pain from the set of proper history, including the back, the gynecologist, and also the GU. When you examine these patients, you also look at a number of issues, you also look at how they have been assembling, what's their education, and as I said, you must examine their back, as well as the neurological and a full vascular assessment. Because again, you can get into brain trouble if you don't do that. I'm not going to remember for a lot of our patients if they're investigated for clearing osteoarthritis in their hip, is we look at the photographs. There are a number of ways that you can use, including MRI, CT scan, occasionally arthrography, and occasionally bone scanning can be very useful. So there we have a patient who's in the 60s and will present to pain their groin when goes into their leg. And you can see from there there's a cyst in the superlateral part, there's also some sclerosis. That will fit in with the patient's symptoms, and they do have a little bit of stiffness. But it's not quite right in what you're seeing, and you may think, well, is this coming from the back? So you take an x-ray of the number spine, which is very stiff, and you see that x-ray. So is the pain coming from the back there, or is it coming from the hip? And one of the easy ways where we come out to see that is to bring the patient into the hospital, inject a needle into the hip joint and using it to control, and inject some local anesthetic, and then get the patient out to walk around. And if the patient says 95% of my symptoms are gone, you know that if you come to a hip patient like patient, they will probably get a very good result. The other important thing you've got to do is you've got to remember that not you can have more and more pathology at the time. We talked about today about pathological fractures. Just remember that you get more and more pathology in a joint. There is somewhere we can also get disagreements which get investigation. So if you carry out a hip replacement in that patient through this more mature approximate female, the patient will have a very poor outcome or result. So it's very important that you look at these x-rays and remember that dual pathologies can occur. Likewise, we've got multiple problems in the whole pelvis through metastatic CA. Also, we have patients, we talk about trauma yesterday today around the pelvis, and we will see patients like that. Patients who have significant trauma to the pelvis and to the proximal femur, they have had sort of surgery, and now they're going to degenerative arthritis. And that's giving them special investigations to work out the best methodology for you to reconstruct that hip, and also hip replacement you should use. Now, the I think before that we want patients to try the physical therapy, send to the physiotherapist, and we want them to try and improve their regeneration and do a lot of exercise. We're using an environment where we have a lot of help with the pain, we try and improve their mobility, a shoelace and lift for the quite wisdom, and clearly there's a lot of we can do in terms of improve the overall down the house, in terms of rails, builders, there's toileting to actually improve the quality of life for these patients, so we can do will require a joint replacement. We also use drugs such as painkillers, such as paracetamol, anti-inflammatories, cortisone inhibitors to limit long-term septic steroid injections, or even iodine and glucose inhibitor, or even infusion to say that those will work extremely very well for some patients with swelling. So, what's the safety of plan? Well, we've got pain responsive to medical control measures. We've got pain we decided is now the hip joint, and we know that we've been clarified our protocols, and they're very important such as night pain, rest pain, we've made sure we've decided the placement of the hip, and that is the way to do it. But before you do that, you must undertake some further assessment of the patient. You want to have a full medical assessment. Make sure that heart's open, that lungs are okay, urine tracts are right, and I have to make sure that they're going to fit and survive. I want to make sure that we're going to put down the hygiene, because I've had a number of patients who've had hip replacement and they've had an infection which is originating from their teeth. We want to make sure that we have no signs of urinary tract infection. And if we find that, then that is our duty to delay the surgery and to treat the urinary tract infection, and then bring them back and do the hip replacement. And of course, we want to make sure if they're fit for the season, and now they're regularly for their elective hip replacement, all patients can now come off their screen. They will have team, but certainly everything we can do. And of course, you want to make sure they have a full year after the training, make sure that the role is satisfactory, that using the immune function, rather than taking the capsule surgery. Special importance, I think, have to be really careful with our meetings, and then follow the cirrhosis. And I'm talking about Joe Bernard, the hip replacements can be very early and very early. I think we talk about the short route to go replacement on these patients. And just remember, if what patients are currently from the hip replacements, they remain from approximately 4 years per abnormal anatomy and might be further medication. So the disease is well, I would say to you that it's certainly been pain, patients having their hip replacements done in any level of insurance, and we can see that substantially, although their pain is not now sort of between 7 and 10 years. And when I have an instance of the BMI over 25, there's evidence to suggest that there's no difference in the quality of life in terms of after surgery. If that might over or being surgery, we will start with people who are ready to go for replacement, because they are going to know in terms of what they want to do in terms of functionalities. On the absolute medication, yes, we've gym for training. You must fill out those sort of things, infection, before you protocol that, and that's why if you've got someone with a urinary tract infection, just make sure that is clear before. Patients who've got progressive neurovascular conditions, spastic paralysis, again, I think is a complication of total hyperplastic. Certain Parkinson's is something that we will consider. They often get worse Parkinson's that is work very handling. And even if we have a patient with a neuropathic joint, with a sharp joint, the important Johnson, and it's progressively stronger joint, the USL. So if you're assessing your patients, if you choose the patient and get the right operation at the right time, the right individual, the right therapy, and choose your patient carefully, you will get yourself a very satisfied customer. Now, what we're going to do with the version replacement is just 2 examples. And the patient who was back and said, well, I'm not very happy about this. My hip is now extremely painful. And you've got to decide what you're going to do with the patients and how you're going to manage them. And what we can do is we can see the clinical, I can take the history and examine them. We run some special radiology, we can do some blood tests, and not provide a report. You need to know, is the pain from that hip? If it's not, where is it coming from? If it's coming from the hip, is it just the fact that it's loose? Or is it maybe the hip is infected and loose? Or when the hip is infected and stable, to give everyone that information. You get the movement resistant. And if you're looking for acetaminophen, they often complain of really pain pain. And family can often describe discomfort down the spine. But just remember this classic start-up pain, which is usually they start walking, it's painful, the pain goes away, and then comes back after they've been walking 15 or 20 minutes. And that's a very
sort of history of patient injury that many people think maybe no one is aware of the hip replacement. And patients who are infected just get this enormous discomfort in their thigh and buttock. So we will visualize how many women as well, maybe it's German, often not. So what we're going to do is see if we can stress the joint to reduce the discomfort. So if we can resist the strain of organism, they may get pain in their groin, and then if we want to check the hip, patients will often go performing in their hip replacement, often find that extremely uncomfortable. And the chief of this problem is described, there are many causes of pain after hip replacement, some from the hip itself, but also from the other causes. And really, when you see these patients and examine them, you want to extreme pain on the right side there to make sure that when you're happy, you will problem now in that hip joint. So, what we can do is we can x-ray. But what you must make sure is this x-ray is not the x-ray you want, because it doesn't show you the typical prosthesis. It may show you signs of loosening. It may show you, as we saw today, that we have a photo of movement inside with a significant thing that is here around the medial side of the proximal femur. And the way in which you temper. But what you must make sure is that you get an x-ray which is distant to the typical prosthesis. And if you've got cement there, goes certainly distant to the tip of cement, because when you come to revision, you're going to have to make sure you don't go to theatre and get caught out by some odd surprise. Now what do you look for? Well, what you're going to see is you'll see a many movements of lines. You can often see those in acetamic cup, it hasn't been well cemented, like to 6 months to a year after hip replacement, but what you will see is where those lines progress. And it's the same amount often between the cement mantle and the bone interface that you will see with their emission lines, and are they getting worse, longer and thicker over time. You will see where the bone masses, and I can just tell you that when you look at the x-ray you see the cortex is thin. When you get out in there and actually carry a revision surgery, the bone quality is much worse at the time surgery than looks like it on the x-ray. Infection, yes, this relative pain, and you often see this sort of illness and stabbing, and then you see this peristalsis around the shaft of the thing, which is very indicative of infection. I find CT scanning very useful in some of those cases we saw earlier, like that lady who had the socket where the tonsils are rolling through. I would arrange for that patient to have a CT, possibly with CT 3D reconstruction. As that gives you a very good idea of what goes to the column, whether you're a contained defect or not, whether you've got enough room in which to put it in the cups that you think, so it will migrate through. So we find CT scan, looking specifically at the anterior post